Hello everyone, my name is Dr. Harem Jaffer, Assistant Lecturer in the University of Suleimani. Today I'll discuss the third part of the gingival recession regarding the surgical management using free grafts and guided tissue regeneration. Let us talk about the free grafts in the management of gingival recession. Free gingival graft involve harvesting soft tissue from a distant site in the mouth and grafting it over a localized recession defect. In comparison to pedicle graft, which involve one surgical site, the free graft involved two surgical sites, one donor site and one recipient site. So, usually the donor site is maxillary palatal tissue. The other main difference is that the grafted tissue doesn't have its own blood supply and therefore relies on a blood supply and nourishment from the recipient site. But in the pedicle graft, we just have a own blood supply from the tissue that's used for recession coverage. But here we depend on the blood supply from the recipient side to nourish the graft in its place. So in order for this to occur, there needs to be adequate overlap of the graft tissue with the soft tissue around the recession defect. Here. So, immobilization of the graft at the recipient site is also essential. The commonly used free graft techniques include an epithelialized free gingival graft and subepithelial connective tissue graft placed either with a pedicle flap or envelope technique or using a tunneling technique. First of all, let us talk about the clinical technique of free gingival graft. As we mentioned in the other parts of gingival recession, first of all, the condition of root surface and the presence of calculus carries contaminated cementum or restoration on the root surface is affecting the outcome of the surgery. So scaling and polishing is very important to get rid from any inflammatory process or inflammatory tissue and work on the clean and healthy gingiva and root surface. And then we do a root conditioning with the EDTA or with a citric acid as prescribed by Miller to make a root conditioning very well and get rid from any contaminated cementum and get a root surface smooth to end up with the new attachment of the graft with the adjacent recipient tissues. So first of all, scaling and polishing plus root conditioning for 5 minutes. Second, in the recipient side, we do two horizontal incisions like here and here at right angle in the interdental papillae, plus vertical incisions at right angle at the adjacent teeth. So we need two right angle horizontal incision and two vertical incision downward. Thirdly, we must draw the area of the recipient site with a tin foil. This is tinfoil to measure the size of the defect and the size to which the graft should be placed. So we need an actual size of the graft to be placed over the recipient site. So draw the area with a dry foil and transfer it to the donor site. Transfer it to the donor site. As you see here, we transfer this tin foil to the palatal site, from which we measure the size of the palatal tissue to be excised to cover the recession area. Then the donor tissue, like here, is excised by sharp dissection. The donor tissue is excised by sharp dissection. This is the excised donor tissue, which is used to be covering the gingival recession. Then we suture this graft on the recipient site with a resorbable suture, which is preferable to be resorbable, and we can use non-resorbable one. But the important note about this is that we must ensure that we remove the epithelial surface layer from here and here. The epithelial surface should be removed so as exposing the underlying connective tissue while ensuring that the periosteum remain intact without removing the periosteum. This is important as the graft doesn't have its own blood supply, and it will initially rely on being nourished by the transudate from the collateral blood supply, while angiogenesis takes place from the host tissue into the grafted tissue. It's also important to ensure that the recipient site prepared large enough to allow adequate overlap of the donor tissue onto the peripheral recipient bed and to ensure a sufficient blood supply. Usually 3 mm extension around the exposed root surface margin is a minimum. 3 mm around the exposed root surface is usually minimum. Usually 3 mm extension around the exposed root surface margin is a minimum. So you must give an adequate room for the flap to be placed and to be nourished well with the blood supply from the host. Also, it's important to pay attention to local anatomy to avoid the greater and lesser palatine nerves and blood vessels. A scientist reported that this neurovascular bundle on average lies approximately 12 mm from the cemento-enamel junction of the maxillary premolars and molars. So it should be here. We must pay attention to this neurovascular bundle as we get a huge amount of bleeding. It's also advisable to avoid the palatal rugae. The rugae is here, as you see it here. We must avoid it as this will result in a poor aesthetic appearance of the graft tissue, which is difficult to eliminate even with surgery. Also, the size of the graft needed depends on the amount of root coverage required and should be measured using a periodontal probe or, as I mentioned, a sterile foil template. The graft tissue harvested this graft tissue should be approximately 33% greater than the amount required. We should excise a 33% more graft tissue than required, as this will compensate for the postoperative shrinkage that will occur. Another important thing is that the graft thickness should be about 1 to 1.5 till 2 millimeter, and the preferable one is 1.5 millimeter. And once the graft has been harvested, once this graft has been harvested, any fatty tissue must be removed using a fine surgical scissor or a scalpel, leaving only the connective tissue under the surface epithelium. Surgical dressing may be used or maybe not. Just one disadvantage of the epithelialized free gingival graft is that it retains the color of the donor tissue. As we see here, the color of the donor tissue is remained. This is often different to the recipient side, and therefore this procedure should be avoided in area of high aesthetic concern. A second technique for correcting the gingival recession in the surgical management is subepithelial connective tissue graft. This graft, first described by Rezge, with the use of an envelope pedicle flap. So he used an envelope pedicle flap with the connective tissue graft. And other scientists described an alternative technique named Langer, which involved placing the subepithelial connective tissue graft with a coronally repositioned flap for covering the exposed root surface. For example, as you see here, we have recession here. After putting the connective tissue graft, then we pull this flap coronally over the graft, then it will cover coronally the connective tissue graft and correct the recession, as well as providing root coverage. The subepithelial connective tissue graft can also be used to increase the thickness of the gingival tissue in areas of gingival recession to reduce the risk of further recession in the future. The procedure involves harvesting connective tissue from the palate and placing it between a split thickness pedicle flap and the connective tissue attached to the underlying periosteum at the recipient site. So let's clinically talk about the procedure. First of all, a partial thickness flap is raised, like as you see here, partial thickness flap, and here, as you see, partial thickness flap, not full thickness flap, is raised. Then a horizontal incision 2 millimeter away from the interdental papillae, here and here, horizontal incision, and then 2 vertical incisions from here to here, away from the gingival margin of the adjoining teeth. Then we extend the flap to the mucobuccal fold, avoiding any perforation. We extend the flap till here without any perforation, as it may affect the blood supply. After that, we smoothen the root surface, reducing any convexity. Here, this root surface should be smoothened, and we should get rid from any calculus, any rough surface, any convexity. Then a connective tissue graft is obtained from the pellet by a horizontal incision. We do a horizontal incision from here. This horizontal incision is 5 to 6 millimeter away from gingival margins of molars and premolars. So this incision here is 5 to 6 millimeter away from molars and premolars, and we just need a short vertical incision from here or here. So you have two-sided flap, a horizontal and vertical incision. Then a sheet of connective tissue, as you see here, a sheet of connective tissue is removed from the underlying epithelial tissue. This is the epithelial tissue. We raise the epithelial tissue and remove the graft, the connective tissue graft. And this graft is freed from any adipose tissue. Any adipose tissue should be removed. Any adipose tissue is removed, and just the connective tissue is remained. After that, we place the connective tissue over the recession defect, as you see it here. We place on the recession defect and suture it with a resorbable suture, and after that we place the flap over the connective tissue and suture it with a sling suture. So after placing the connective tissue on the denuded root, we should suture it on the underlying periosteum with a removable suture or with a resorbable suture. Then after that, covering the graft with a partial thickness flap and sutured with a silk. At least half or 2/3 of the graft must be covered. Then we cover the area with a tin foil and pack for 7 days if necessary. We have another technique which is named a tunneling technique, as we see here and here. This is a tunneling technique. We make an incision here and here and here. According to the site of recession, we make incisions underneath the interdental papillae, and we make a pouch or a room for graft to be placed, and we undermine all these areas underneath the free gingiva and attached gingiva, and after that we place the graft and we push the graft coronally and suture it in its place, and this is named a tunneling technique. This is more preservative, and you just make a pouch and insert the connective tissue graft and suture it in place, but it's more delicate and you should be precise in immobilization of the graft and suturing in its proper position. Then we are going to talk about the guided tissue regeneration. Various authors have described the use of resorbable and non-resorbable membranes for guided tissue regeneration to treat the recession defect. This involves raising a full-thickness flap around the recession defect and placing a membrane and covering it with a coronally advanced flap. The aim of this treatment is to prevent the formation of long junctional epithelium. If this membrane is not placed here, this tissue the gingival tissue, connective tissue, will adhere to the root surface by long junctional epithelium. So the main aim is to treat and to prevent the formation of long junctional epithelium, but instead allow normal connective tissue attachment to the exposed root surface. Compared to the traditional grafting techniques, as we described above, the guided tissue regeneration has the advantage of eliminating the need of second surgical wound. But if we use non-resorbable membrane, so a second surgical procedure is required to remove the membrane. Results have shown that there is no significant difference in the outcome between resorbable and non-resorbable membranes, while results of guided tissue regeneration have shown significant root coverage is achievable. But the outcome is no better than the traditional techniques that we described above. And on the downside, they carry the risk of membrane exposure, leading to infection, foreign body reaction, and difficulties in primary wound closure. So the disadvantages of this technique is sometimes membrane exposure, which may lead to infection or foreign body reaction and difficulty in primary wound healing. Let's talk about the clinical techniques for doing a guided tissue regeneration for the treatment of gingival recession. First of all, we create a flap. Like here, for example. We create a flap using intrasulcular incision down there, intrasulcular incision inside the sulcus, and oblique releasing incision, and we do an oblique releasing incision to release the flap, and we made the flap beyond the mucogingival junction. So we elevate a full thickness flap to mucogingival junction and partial thickness flap beyond this area. So till the mucogingival junction, we elevate the full thickness flap, and after that we elevate a partial thickness flap. As usual, a thorough cleaning and smoothing of the root surface is done. Then we trim a Gore-Tex membrane to cover the root and 2 mm of crystal bone, as you see here. With this membrane, we cover the root surface and 2 mm of the bone also. Then we pass a suture through the apical part of the membrane and trying it in outside and tighten it as to bend the membrane. Then we place the membrane on the root so that the bending suture is on the bone. This creates a space for the tissue proliferation and it forms a pouch for a new regeneration. As you see here, you will see a regeneration of normal periodontal ligament and cementum, because this membrane will prevent the healing by long junctional epithelium. Then we suture the membrane with a sling suture, as you see here. Then displace the flap coronally as possible to fully cover the membrane, and place the suture from the coronoproximal edge of the flap over the contact point to the palatal gingiva. Then we place the medial and distal subperiosteal suture at the base of the flap, and we don't apply any pack. Regarding the postoperative instructions, first of all, avoid brushing the surgical area for at least 3 weeks while initial healing occurs. During this time, the patient should be prescribed 0.2% of chlorhexidine twice daily. And immediately following surgery, the patient should also be advised against lifting your lips or pulling your cheeks to look at the surgical site. This can cause displacement of tissues which have been carefully sutured into position. The sutures will remain for 10 to 14 days, as it takes about approximately 8 to 10 days for the connective tissue union and adequate blood supply to develop within the graft tissue. At the review appointment, if sufficient healing has occurred, the suture should be removed and the adjacent teeth can be gently cleaned with a prophy paste and floss to remove any plaque deposits. If plaque deposits are seen, so gently remove with the cotton wool soaked in 2% chlorhexidine gluconate. After approximately 3 weeks, when sufficient healing has occurred, the patient can be advised to use a soft bristle baby toothbrush. At 4 weeks post-surgery, if sufficient healing has occurred, the patient can resume a normal atraumatic toothbrushing regime. Complete healing often occurs over several months, and any probing of the site should be avoided for at least 6 months. In brief, free grafts are an alternative to pedicle grafts and are the treatment choice in areas where the gingival biotype is thin or there is a lack of keratinized tissue. Guided tissue regeneration or the use of allograft and xenograft avoid the need for second surgical site. The subepithelial connective tissue graft with a coronally advanced flap is considered to be the gold standard of the grafting procedure. This is the conclusion of our lecture today. Thanks for your attention.